Okay. All right. All right. Welcome to the Centennial Critical Care Journal Club. Not Centennial, just earmuffs. Every 3 weeks. So we're gonna get very active again. You know, during COVID we had a little bit of some meetings were canceled and stuff like that. But we are gonna get very active. So be ready. This is a good kickoff for the 2022. We have a meeting that is dedicated for like themed ECMO.
I already signed.
So we will start with there's gonna be like fire shots of presentations. You know, each presentation is gonna take about 10 minutes, and then we're gonna 12 minutes, and then we're gonna take some time for questions, and we'll take it from there. Everything is recorded. It's gonna go on YouTube. So if you don't wanna have anything on YouTube that is embarrassing, don't do anything embarrassing. All right.
Sign a consent for this.
Yeah.
All righty.
Yeah. So we can start with Professor Hosanna Mamata, and she is a third-year resident in the ER at BI. She's going to Connecticut next year, and she's expecting a baby too.
Oh yeah, in June. Yay.
All right. So Hosanna has been with us for about a month now, or 3 weeks, and she is going to present to us ECMO and COVID.
Yes. All right. So I'm just going to do a little bit of background on ECMO. So ECMO, as we all probably know, stands for extracorporeal membrane oxygenation. Been used since the 70s, really initially for neonates and babies. And it's essentially the main role is for cardiac and respiratory support for reversible cause of failure. So indications, sorry, there's so many stuff. So indications for ECMO. So essentially, I mean, it's a temporary thing. So you want it to be a bridge therapy for things like transplant, LVAD, cardiac arrest, toxic like an overdose, hypothermia, arrhythmias, or ARDS. So it's not a permanent solution, obviously. So we need something. If it's a disease we're treating or condition we're treating, has to be something that's has basically an end game. So contraindications.
1 second. Who's here on Zoom?
Yeah.
Dr. No is on Zoom.
Okay, and we have Lady Gaga and who else?
Stacy.
Stacy. That's it? All right, very good. Sorry, keep going.
So contraindications on the other side, so severe neurological injury, end-stage malignancy, significant immunosuppression, severe coagulopathy, this is a pretty invasive procedure, and early dissection will be chronic organ dysfunction. So again, a lot of the contraindications have to do with like bleeding or coagulopathy, and also if these patients, if it's not, this is a temporary way to kind of settle patients. If there's not really like an end game or end goal to it, then that would be a contraindication to ECMO. So how does it work? So just kind of globally overall, it drains deoxygenated blood from a vein and pumps it through this membrane oxygenator, and the carbon dioxide removed, O2 supplied, and it gets put back as an oxygenated blood into the patient's vein or artery, depending on if it's VV or VA ECMO, which I will talk about a little briefly. So just this cartoon kind of shows, deoxygenated blood goes in, and then becomes oxygenated in the oxygenator, and then gets put back. So basically patients can keep circulating oxygenated blood for their tissues. So 2 types of ECMO. So there's VV ECMO, and this is really for isolated lung injury, and it provides respiratory support only, not circulatory. So it's really for patients who are having respiratory failure, but still have sufficient or good cardiac function, because they still need to be able to kind of circulate the oxygenated blood on their own. So things that VV ECMO is really used for is lung contusion, smoke inhalation, the post-lung transplant, and ARDS, which is kind of what some of these articles today that we'll talk about for COVID patients. And the VA ECMO is the one that can do both cardiac and cardiopulmonary failure support. And these are things like drug toxicity, myocarditis, cardiac trauma, ACS, things that can affect the both systems. So ECMO and COVID-19 patients. This isn't the article that I'm presenting, but it was based off of this article, a little bit more in response to it. This came out in 2020, I think around April, I believe, that said basically poor survival with the use of ECMO in ARDS patients, for COVID patients. And it was a very small study that, essentially only looked at 4 articles all from China, because this was really.
Do we have that one? We don't have that article?
Yeah, I
No.
didn't, sorry, I didn't send
No,
this
you have
one.
one for each. This is an article in her presentation.
Oh, okay.
Yeah, this was, just kind of a preliminary thing. But they essentially looked at 4 different studies, and this is kind of like the numbers that people were reporting at the time, that the survivors on ECMO who with, COVID-19, it was just like a very poor outcome. So they published this early in the pandemic and saying maybe ECMO isn't really helpful for COVID-19 patients, and obviously, the study authors for this said we have to do a bigger study. So this is the article that I'm talking about today, a little bit more in detail, and it's basically ECMO supporting COVID patients, and it's an international cohort study, and they looked at basically the ECMO registry that covers information and data from
The ELSO registry is very.
ELSO registry. That. Can I get rid of this scanner thing? No.
Which one do you want to get?
No, I just want to
Top
get rid of the top one.
Yeah.
So the ELSO registry, they got all the data from this registry. It's an international registry that covers over 200 hospitals in 36 countries. The US is part of this registry, so it's, Japan, China, Brazil, a lot of major countries. And they essentially try to characterize the epidemiology, hospital course, and outcomes of COVID-19 patients who are on ECMO. And they looked at data from January to May of 2020. The primary outcome the authors in this study looked at is in-hospital death and a time to event analysis at 90 days after ECMO was started for these COVID patients. And the secondary outcomes they looked at were percent of patients remaining in the ICU, hospitalized, DC to rehab, et cetera. So kind of the dispose of these patients and how many percent of these COVID patients on ECMO ended up where. So briefly, the median age of the population they looked at was 49. Most were male, and then the race and ethnicity are pretty kind of diversely spread out. 14% Black, 33% white, 15% Asian, and then I think it was like 21% Hispanic. So the main, this is kind of the characteristics of these COVID patients pre-ECMO, kind of what some of the strategies and the treatments they were receiving before they went on ECMO. As we kind of do now, today too, 60% were prone at one point. There was 72% that they used, neuromuscular blockade. 60% of them were on pressors at one point. And similarly, steroids, 41% on steroids, and about 52% were on hydroxychloroquine. And this is pre-ECMO. That's kind of what these patients were on. And so this is kind of the DISPO characteristics that I was talking about earlier that this study looked into. And they actually divided the cohort into just like everyone. They looked at the full cohort, which meaning like everyone with COVID-19 on ECMO, and then they separated also into ARDS cohorts, like people who within that cohort that met the ARDS criteria that they had. But anywho, about 30% of them were discharged alive to home or to an acute rehab center. About 10% got discharged to a long-term rehab facility. About 17 went to discharged to another hospital. And about 5% remained in the ICU at night. Then this is all at 90 days. And then about 1% were still in the hospital, but out from the ICU, so like the medical floor. And then about 37% of the COVID-19 patients who went on ECMO had an in-hospital death by 90 days. And this is just showing the hazard ratio for mortality, basically associated what factors were kind of associated with patients who ended up dying with COVID and on ECMO. It's the kind of things, I think it makes sense, things that we can kind of guess. Older age was associated with higher mortality. If you're immunocompromised or already had, COPD or chronic respiratory disease, or if you had a pre-ECMO cardiac arrest. And it kind of makes sense because, if you were sicker and then you went on ECMO, which is kind of like the last resort, you were probably gonna have a higher risk of dying. So the authors concluded, contrary to the first study that I briefly talked about that didn't really recommend ECMO for COVID-19 patients in ARDS, they said that, with the mortality being around like 37%, and there's a good chunk of 70% of people who actually survive with, at least at 90 days on ECMO, that this is something that, we can use to kind of support them when they're in severe hypoxemic respiratory failure. Some of the limitations of the study, so obviously this registry doesn't have all the ECMO cases worldwide. All the hospitals that are registered with this registry are kind of one of like them, the ones that have a lot of resources, and even through the pandemic, they were able to like send all this data to the registry. So, and I think the ones that were not consistently doing that were eliminated from the study. So it's not a like a holistic worldwide view of all the data, and also not all patients complete their ECMO course at the time of reporting at 90 days. So that could underestimate the prevalence of complications that happened during their ECMO. And obviously it wasn't a randomized controlled trial, so you can't really draw any definitive conclusion off of this. And also the final outcome is not known for all the patients that was discharged home or went to an acute rehab center, because after 90 days, after 91 days, they could have died, and that, but we don't know what that. So overall, I thought it was, it was an interesting study that kind of looked at all the international numbers compared to kind of the limited, initial preliminary numbers that they looked at in the beginning of the pandemic, and I think it gives us like a better view of how we can use ECMO for the COVID-19 patients. And that's it.
Great, thank you very much. So question, so I didn't understand one thing. So basically they're saying that they randomize, so there are the two cohorts that they're comparing to each other are ECMO, COVID patients on ECMO.
They're they're all COVID patients on ECMO,
Yeah.
and then within that subset was the ARDS, so whatever thing that specifically met the ARDS criteria were the subsets.
So it's
that
just a
they were
subset
using.
analysis
Yeah,
for patients with ARDS,
yeah, which, a lot
which
of
is
them
really
were.
weird.
Yeah,
It's
which
like,
a
why
lot of
would you
them
put
are.
somebody with COVID on ECMO if he doesn't have ARDS?
I think, that's a good question. I thought, my understanding was, I'm not sure exactly if how their definition of ARDS is, if it's the same as where it's used everywhere, but, I guess my understanding was that some patients had other failures, not just ARDS, and they kind of took just the ARDS specific pool to kind of analyze that for the COVID patients.
And then, so everybody in the study is ECMO patient,
They're all
right? There's
ECMO
no
patients, yeah.
comparison of the non-ECMO
No,
patients, right?
there was no a control group that's non-ECMO. Because this is straight from people who are on ECMO that got registered in the ECMO registry.
So they're saying here that the full cohort, they had 79% ARDS patient. Yeah.
Yeah, so it's
So only 21% of them did not have ARDS, so maybe they had PE.
yeah, they had other complications.
Yeah, okay. Come on, you guys. So, Dr. Grazioso, what do you think?
Well, it's just an observational study that mostly is really just looking at evidence for the concept of ECMO. I think that's all it offers, but it does, because the other study, obviously very small, I don't know, as I looked at it, maybe 13 or 14 total patients that got ECMO, one survived.
Right.
So too small to say we shouldn't use this. I think just as proof of concept, the idea that 30% may have survived to discharge to a non-terrible outcome is okay. It's better than if they needed, assuming, of course, that they met all other pre-study criteria for ECMO, then if you can save 30% of people who 100% of whom would have died, then that's, you know, it's an argument for the concept.
Yeah.
I think that's all it can say.
Average peak was 14 to 15 in the two cohorts. The peak inspiratory pressure was 33 to 34. This before enrollment. Both of them had 100% FiO2. And PF ratio was 72 in the full cohort and 72 in the ARDS cohort, which is exactly the same. So I think probably the 20% that did not have ARDS, they probably were PE. You know, like COVID was PE. That's why it didn't need to. So because ARDS has 3 criteria, right? Bilateral infiltrates, PF ratio less than 200, and not CHF. So the fact that they have 20%, that means that probably they didn't meet the bilateral infiltrate part of it. You know. Anybody? Any other comments? What is our respiratory people? Yeah? All right. So you know, if you have any comments, we can still comment on the next one because it's all gonna be ECMO today. All ECMO. Thank you very much. So, and this is the time where everybody take the pizza and take one from each file.
Inside.
You know, this, and a pizza. Please. Please do it for me.
Yeah, I'm ready.
All right, the Professor Gestapo. We're gonna do. Professor Gestapo was the first one who actually did his homework. So, kudos to Professor Gestapo. He's ready.
I wasn't the first one.
Oh, you are the last of the last. But it came out good.
That's,
It was amazing.
that's him.
All right, is Ryan on the
You need
Ryan?
the link, you just send him the link.
He wants the link. Can you send me? I can't send it. Can you send? Can you show me? You use your email on the phone?
Email, no. Oh, yeah, yeah.
I see you now.
All right, can you tell Ryan it's on his email?
The sterile.
On the
I have
hospital
a
email.
feeling.
All right. Well, Professor Gestapo, please.
Wanna get started?
Yeah.
All right.
And so, Professor Gonzalez is going to talk to us about COVID, ECMO, and the risk factors for mortality when you are on ECMO for COVID-19. That's really a nice follow-up for the previous study, because we know the mortality rate is 37%, and we're going to find out what are the risk factors here. Go ahead, Professor.
Yeah, so, like you said, I'll be discussing the risk factors of mortality for patients who are already receiving VV ECMO for COVID ARDS. This was a study done, published last year in the collaboration between University of Minnesota Medical School and Mayo Clinic. And as Dr. Sirwar said, this is a big question for us because if we're trying to implement ECMO in this hospital, we're a small hospital, we're gonna have limited resources. And so we gotta figure out which patients are gonna do best on ECMO for our population. So hope this can determine who's gonna be the most, responsibly, who would do well on this and who has a higher chance of survival when we place ECMO on these patients. So as Hosanna said earlier, ECMO is extracorporeal membrane oxygenation. It's a form of prolonged mechanical and mechanical cardiopulmonary support. There's 2 types. In this scenario of this paper, as well, what could be implemented here is VV ECMO, so veno-venous ECMO. You would simply put 2 catheters, one that would go into the SVC and you put your second catheter into your femoral vein and all the way up to the IVC, and you would pump and you would oxygenate, and it's a way to continue oxygenating the patient despite having diseased lungs, and you actually give your lungs a rest during this time to heal while you're oxygenating them with this device. So this study itself is retrospective. It's retrospective, it's an observational cohort study. It's quite small. It was only 46 patients who were supported on ECMO, and it was about an 8-month span of patients. But it was in the meat of the pandemic in 2020. The primary outcome was looking for survival.
These dates give me PTSD.
I know.
That's PTSD right away.
Yeah. And so with this alone, we can expect, we shouldn't expect randomized trials. People were trying to save people as best as we could with the resources we had. So it would be asking a lot to ask for a randomized control trial in the middle of the pandemic, but this is the best we could do during that time. But here we see the primary outcome was survival to ECMO decannulation and 60-day follow-up. And then some secondary outcomes were in-hospital mortality, length of stay, days of intubation, mechanical ventilation, as well as patient complications.
You can move this column if you want or whatever.
So one of the big things of the demographics, here we see that they broke up, so everyone here is on VV ECMO, and there was a total, as I said before, of 46 patients, of which 30 survived in this time span and 16 were non-survivors. So this alone, of 65% of these people survived on ECMO, which I think is pretty amazing. Like if you had 12 patients that needed ECMO and they got it, 7 to 8 would survive, which is amazing during this time. So it's pretty remarkable. But in terms of they broke down, the characteristics between the survivors and non-survivors and how we can help determine. One of the biggest things that even Hosanna touched on earlier was age. Age can be a big risk factor. And I go on the next slide about essentially once you hit that 50-year-old stretch mark, when you hit 50 years old, your mortality kind of skyrockets.
That's not old.
For ECMO, unfortunately. Unfortunately
Oh
for
my
ECMO.
God.
You just got an enemy.
Hey, data. Hates the data. So again, unfortunately for these patients, once you hit around 50, they had a lesser chance of survival on ECMO. But interesting enough, it was, by race, and even in this scenario, again, it's a small study, so take it with a grain of salt, but even different medical history didn't have a big difference in the survivor and non-survivor. So if you're obese, you had hypertension, you had asthma, COPD, that didn't really make a big difference, at least for this study, in terms of who survived and didn't survive. At least your initial demographics was your age was a choose determining factor. Mind you, again, small study, and that was mostly male, and it would make sense because people who got sick, who required ECMO, were mostly older men who got really sick and required ECMO. But again, take it with a grain of salt.
Yeah, small numbers. All the subgroups are small numbers. Like you see COPD.
Exactly.
3 is,
Yeah, so they're all small numbers.
Yeah, small numbers. It looks like it's trending towards COPD is a factor, but it's very small number.
Exactly. And this was again touching on mortality by decade in this study.
Can you go back one?
Yeah, of
one
course.
thing? Just I want to show you something. I'm looking for it actively. It doesn't say end-stage renal disease, right? That's what we were talking about. These
Yeah.
people with end-stage renal disease on dialysis, they don't get severe COVID. They just don't. I think the filter has some magic.
Yeah. So again, touching again on mortality by decade, we see that once you hit above 50, unfortunately, you're going to have a higher risk of mortality. But again, this study was mostly composed of people who were in their 50s. You can see by the size of the population of the study by the size of the dot. So, we had a lot of people in their 50s, the next bunch was in the 60s, and then 40s and 30s. But you even see that the group in 50s and 60s had a higher mortality rate compared to those in their 40s and 30s who received ECMO. Here are some more pre-ECMO data. So before someone gets put on ECMO, can you look at, kind of what characteristics they had, they can determine are they going to survive or not, at least give you an idea. some vent settings, where that was quite interesting, is someone with a higher peak pressure, so survivor versus non-survivor, actually did better.
What, so wait, survivors?
Had a higher peak pressure on vents before ECMO
Wow.
than those who didn't.
That's unbelievable.
But then, like, you know, your peak was they're very similar.
Yeah.
FiO2, you actually
So the driving pressure was higher than the survival.
yeah.
Wow.
Some other significant differences was PFO2, the PF ratio, which is your arterial PO2 divided by your FiO2. And in context of medicine, once you hit below 300, you're hypoxic, and you keep going lower and lower to 200s. These people are already really low. Like, the difference here was 76 and 62, which is already quite hypoxic and pretty low. But still, those who survived had better ratios than those who did not survive. Other ones that were important were days of antibiotics. So patients who received more days of antibiotics usually did worse. So in here we had 14 versus 25 for non-survivors. And the other one here was transfusion. So patients who required more transfusions usually did worse on prior to ECMO placement. And then the SOFA score, the sequential organ failure assessment score, which we can use, that also helped determine mortality prior to ECMO placement for these patients.
Yeah, and you see, these are all like weaknesses of the study, I mean, because you know the two groups were not equal.
Exactly.
You know, and it's a freaky thing that he's saying that you know the survivors have higher peak airway pressure, which
Yeah.
usually indicate that they're
The
not going to be
opposite.
survivors. So,
Exactly.
but it's all a function of statistics and you know small number of patients probably.
In terms of hospital time course, there actually was no significant difference between these two groups. I think the reason being is, if you see here like ICU length of stay, survivors had 28 days on average, I'll go back, and then the non-survivors had 41, which in itself is a big difference. But if you look at the interquartile, you know, there is a big range. So there's much overlap. Because of that overlap and discrepancy between the two different groups, there was no significant difference. But on average, you could argue that there was a difference in length of stay, as well as, you know, length of ECMO, 19 days versus 33 days. But statistically, there was no difference for this
So
study.
basically, it's you know people who survive just roughly 19 days.
Yeah.
Once you start going above 33, then you know
Yeah.
you're not gonna survive.
Yeah, you don't want to go too
Right?
long.
That's what it looks here. Yeah.
Yeah. Some interesting things that I found here was we also followed inflammatory markers, which we've been doing a lot during the pandemic. And so the big difference here, these were inflammatory markers done post-ECMO. So everything before was pre-ECMO. Here is once ECMO was started, can you look at the inflammatory markers and determine who's going to do well with ECMO and not as well. And so for here, at least up here, we see that, so here on the bottom here, we have kind of pre-ECMO, day of ECMO, and then days out from ECMO, and different inflammatory markers here. So, and the stars represent a p-value less than 0.05. So for these patients, the first one I see is white count. So the dark line here, it's hard to see, are non-survivors. So the darker line are people who did not survive. So for here, it seemed that in general, if you had a higher white count throughout ECMO, you did not do well. Specifically in days 1, 2, 3, 1, 2, 3, in which you had a white count of 17. Platelets, the darker line here representing the non-survivors, generally had lower platelet counts than survivors on ECMO, and especially towards the end, that we had, you know, that could be a factor. And then also towards, you know, day 14 and past, if your dimer started to shoot up, you also had a higher risk of mortality for these patients. So again, recap is higher white count, low platelets, and elevated dimers were risk of post-ECMO mortality. And then we also trended CRP, ProCal, and ferritin, but didn't have any real significant differences there.
I just want to say something. You know that Boston hospitals, except Mass General, you don't do propostone. I mean, what's going on there? That's another. That's
The only thing, Gustavo, if you just go back to that, I would only point out, I don't know what any of that means, because there are over 40 endpoints
Yeah.
So we would expect to find at least
Something,
two.
yeah,
So I just don't
statistically.
know what that means.
Yeah, the
Most of
0.05.
them cross each other,
yeah,
and if you count up every one of those possible nodes as an outcome,
Yeah.
there's more than 40 endpoints,
yeah.
so.
And have a 0.05 chance.
It's
of
hard
having
to
a-
say.
By chance, you find a difference, you're gonna hit something.
Yeah, I mean, yeah, maybe having a very high white count and having very low platelets is bad, which we kinda know.
Yeah.
We generally
Yeah.
think already. All right,
But these are days of ECMO, right? So
Yeah.
they notice like later, so this is 21 day, this is 21. It looks like 14 to 21 days, something happens where the two curves in most graphs are actually separated from each other a little bit. Like if you look at the three curves on the right, about 21 days or 20 days, there is separation of something. I don't know if that means anything, but if you look at the whole thing, you're right, it doesn't make any, it doesn't give you any information. But can we infer anything? I don't know.
Could represent patients leaving the hospital.
What?
Could represent patients leaving the hospital and the sample being studied after their
Oh, yeah,
discharge.
since a lot of them required ECMO for like 20-something days for the survivors
Oh, okay.
compared to the length of stay. I don't know.
Yeah, you're right.
Some limitations, there are many in this study. For performance, it's a very small study, and of those mostly men. And, you know, it's, again, at the time of the pandemic, it would ask a lot to do a randomized controlled trial during this time. So the best we could do is a retrospective study, but hopefully we can grab some information from it. And, you know, another issue was with this biomarker is, as we know, it's hard to get labs on time. And so you're gonna have a lot of missing markers. So I think, you know, here they've noted that they had a missing time point of their different markers by 9.5%. So that was also an issue for the study. And the other limitation, as we know, is the heterogeneity of COVID itself. It's difficult to predict who's gonna do well and not do well during this time. But kind of quick takeaways from this is, you know, at least in this study, of the 46 people who had COVID who required VV ECMO, 65% of them survived, which I think is pretty great. And then you also have the risk factors prior to cannulation for mortality, which include older patients, lower PF ratio, higher SOFA scores, increased antibiotic days and transfusions. And then post-ECMO mortality, you can talk about white count, your D-dimer, and platelets. But again, this is all taken with a grain of salt in the context and limitations of the study.
Nice.
That's it.
Thank you. No. Thank you very much.
They
Good job.
mentioned, or did I,
You want
Gustavo, did they mention or did
I
I
don't know,
miss it
probably
where,
regular, just 'cause.
at what point in the disease course did they start that ECMO? Like, did they
Yeah,
control
there
for
was no
that?
like in terms of like, you know, how many days after COVID, or like was there like a point in which their vent settings were so high they had to go to it. They didn't really describe the point to start ECMO.
Okay.
But that would have been helpful.
Thank you
Did
very
they
much.
address it anywhere in the article, Gustavo? I was trying to find it in the abstract. Let's say somebody makes it off ECMO or is decannulated. Were any of those patients decannulated because they were made CMO?
Oh yeah, that wasn't mentioned either in terms of like status changes.
Right, cause
during-
then it would be hard to, like,
Yeah.
maybe they survived to decannulation
And that
because
was-
they were made CMO, I don't know.
Yeah.
I just didn't see it.
Yeah, I see that.
All right, and this is our child Pew number 1, child Pew plus 1. That's the nickname. Professor Drake. She's the fastest preparer for this. You give her 2 hours, she prepares for the journal club. So, well, she's gonna tell us about the long-term survival. So you did ECMO for somebody, what happens when they go home and they go to rehab and all those things?
Yeah, so this study actually brought up a lot of stuff that, I mean, we don't really we do think about in the ICU, but I do think it's good to bring it to light of like, what is the patient's like quality of life after the ICU, after doing all these intensive things. For like example, what we have now is like, we have patients on CDBH, like what is their life like afterwards and kind of following up. So this study looked at more long-term survival and quality of life after being on ECMO, and it was veno-venous ECMO. And it's just in patients with ARDS, it wasn't specific to COVID or the flu, it was just ARDS. He said he used the computer code and the stuff that was in the link, but it wouldn't allow him to join this. He said he was the only one on the meeting, so I'm not sure why.
Okay.
But there's other people on the meeting, so. Alright, there we go. So I'm just gonna move this. Alright, so this study was a retrospective study from an ICU, a 30-bed unit at the University of Freiburg Medical Center in Germany, and the data was collected from October 2010 to June 2019. So they actually had a total of 289 patients overall from this unit treated with veno-venous ECMO. The median age of this population was 55 years old, with 67% of those patients being male. And and then they followed up the patients after their hospitalization, with the average follow-up time of about 3.9 years. A total of the 289 patients, of the ones that survived was 129, and of those 129 patients, 94 of those completed the follow-up.
This is all ARDS, not ECMO only, right?
Yeah.
Yeah.
Or no, it's
Not
it's
the-
ECMO, it's patients that were treated for ARDS with
For
ECMO.
ARDS with ECMO,
Yes.
yeah.
And it's the patients that were treated for ECMO, from this ARDS, the patients were already intubated. So the patients had been trialed on mechanical ventilation and failed due to hypoxia or hypercapnia. So they had not just jumped to ECMO right away, they had tried, but then the patients failed that and needed further treatment, so that's why they progressed to ECMO. So the end total of patients for the results I'll show you guys at the end was a total of 53 patients who completed the full follow-up and all the data collection. So in general, the study did look at, there has been studies kind of like with Gustavo, and I miss Hosanna's unfortunately, but there is other studies about ECMO and then how patients do with it and the benefits of it. So this study did point out patients with ARDS can benefit from veno-venous ECMO. However, due to the acuity of these patients, there is a high mortality rate, and that's just a fact. These patients are so sick that they do pass, but ECMO has been proven to benefit patients as well. And it did make note of the complications of ECMO in general, being infection, bleeding, thrombosis, and embolisms. And even though the patients that survive ECMO therapy, they're severely compromised, and after discharge subsequently die due to other complications. So it is difficult to predict the long-term survival, which is why they want to do this study. So basically the endpoint of this study, of those patients, of the 289 people enrolled, the primary endpoint was the long-term survival after hospitalization, and the secondary endpoint was the 6 and 12-month survival rates and the health-related quality of life. And veno-venous ECMO, like I just said, was put in patients that they had failed mechanical ventilation. This hospital, which I thought was interesting, does use bilevel as their primary mode of ventilation, so that's just of note. And they defined it as the patients that were failing mechanical ventilation, they defined it as the lung protective ventilation, and that was defined as a PEEP of less than or equal to 15, a plateau pressure less than or equal to 30, a driving pressure less than or equal to 15, and an FiO2 of less than or equal to 50%. Typically, the ventilator settings for these patients in this study was a PEEP of 15, a plateau pressure of 25, FiO2 of 50%, and a respiratory rate of 10. And they used several different questionnaires in different scales. I listed some of them below in the last bullet point. But these are basically all different scales to measure different things. So they used the SF-36, which is the short form health survey 36, the SGRQ, which is the St. George's Respiratory Questionnaire, and the hospital anxiety and depression scale for the health-related quality of life assessment. Then they compared this against the general German population. For predictors they also looked at predictors for hospital survival and 6-month survival. They used respiratory questionnaires. and compared that with a COPD reference cohort and the general population, the European general population from a different study that was actually based in Spain. So they did compare their respiratory quality of life after the fact with against a COPD group and against a general European population, so not to just compare it against another sick group, it was to compare against another general population. And they also compared results with previous ECMO studies and ARDS cohorts. And they also compared in general the quality of life against like the general German population as well, which I thought was interesting. So this is, here, I'm just trying to move this a little bit. So this is kind of just going over what I was talking about with the number of patients in this study. So total of 289 people overall enrolled. It just kind of gives a better visualization of like how many people actually were followed up and how many people were enrolled. With hospital survivors of 129, total of 35 people were lost to follow-up after discharge. 94 had a successful follow-up. 23 of those patients died before the follow-up, which was done in 2020. It was, I believe, was February 2020 to about like September 2020. All these studies and everything were done after the fact, and like throughout the course, because the study was from 2010 to 2019. So the people from 2010 had a longer follow-up, but they survived than the two people in 2019. And then the overall total, everything completed, was a total of 53 people.
That's, they just, so they didn't have a specific date for, so some people had a 10-year survival, some
Yeah.
people had 2 years
So
survival.
the thing that I also thought was interesting about this study is like they enrolled anyone with venovenous ECMO with ARDS throughout like 2010 to 2018. Like they weren't exclusive, but they did take into account like their comorbidities and everything that was impacting their hospitalization, versus just be like, oh, it's the best of the best, it's the cream of the crop. It was everyone was enrolled, and then they even included people like that 289 people. Though that population represents even patients that died, but then 129 of those people survived ECMO and were discharged.
And then 59 survived for whatever period of time.
Well, the 54 was complete follow-up.
Yeah.
So there was some that actually did survive, but there is people that like kind of fell out of follow-up throughout the way. But so as far as the results now, so age, lung fibrosis, liver cirrhosis, immunosuppression, and fungal pulmonary infection were associated with increased hospital mortality. I put the p-values corresponding with those, and a lot of them were pretty significant. Which I thought was interesting was bacterial pulmonary infection was associated with increased hospital survival. Survival! I reread it like 5 times, I'm like, is this what it really means? Survival! So, and they got these via like a bronchoalveolar lavage, like we do. And in patients with successful follow-up, underlying pulmonary disease, long-term O2 therapy, mechanical ventilation of greater than 7 days prior to ECMO initiation, and the duration of ECMO were associated with a reduced 6-month survival. That's just kind of things that they found in their study. In a logistic regression analysis, the only duration of ECMO support, only the duration of ECMO support was an independent predictor for 6 months mortality with a p-value of 0.01. So they found that these, the 6-month survival was reduced with these factors I just listed, but in a logistic regression analysis, only the duration of ECMO support was the only factor that was a predictor for 6-month mortality. When they further analyzed it in a landmark analysis, it showed the pre-existing conditions of venovenous ECMO were no longer associated with the probability of long-term survival, which was pretty interesting. So it kind of like took away those pre-existing conditions, like, hey, you can have really bad lung fibrosis, but that doesn't really matter at your 6-month survival. It was only like how much time you were actually on ECMO was the only statistically significant factor.
And did they have a time cutoff? Or they just like it was a...
Yeah, there wasn't like 7 days and you're done. Like it was however long the patient needed or if they passed. Yeah. And this study didn't actually, like they did point out some of the like an average of the time, but they didn't specifically say, oh, patients that were only on 2 days on ECMO did better than the patient that were on 7 days on ECMO. There wasn't like a statistically significant duration of time. It was like longer is better, but
in this graph, they
worse
put
better.
7 days as a duration.
Okay,
In that particular graph, they just divided
oh
by
yeah,
7
with the
days.
odds ratio, yeah. I ignored that for that was giving me statistical class PTSD.
PTSD,
When I took
okay.
stats in college, I just kept turning. And a great number, so then it also looked at the patients that had successful long-term follow-up, which is a total of 53 patients. They were working, had high SF-36 scores of 72.9, lower levels of respiratory limitation and lower levels of depression compared to the general public. Reference ECMO and ARDS cohorts also showed comparable levels of health-related quality of life. So I did compare, again, these patients against the German population and against patients in a similar pool of previous studies. So a great number of the patients were working, so 82% of the patients that were followed up were working, and 61% of those patients were continuing their previous job they had prior to hospitalization, which I thought was interesting, because that's a big factor of how is my life gonna be altered after I get this intensive thing and now I have to resume my life as previous. That's a big factor. 8% of those patients were newly disabled and permanently disabled, and 10% of those patients were already out of work before being on ECMO. And it didn't like specifically say why, but I guess is other comorbidities that were existing or other circumstances. There was a low extent of restrictions observed. The only difference was with lower quality of life against the general public was general health and physical limitations of these patients, but overall, like mood, psychosocial stuff, that was kind of on par with the rest of the German public. The level of anxiety was comparable to the German reference cohort, so patients of this group were just as anxious as patients in the general public. And actually, the depression level of this ECMO group compared to the general German public was lower, which I thought was pretty interesting. And patients in the study were a similar age and gender to previous ECMO cohorts, but this study had a high rate of relevant comorbidities, particularly lung fibrosis, immunosuppression, and liver cirrhosis, resulting in high hospital mortality. So it is making the point of that, yes, this was all compared to previous ECMO studies, but these patients in relation to those did have higher comorbidities, such as lung fibrosis, like all of those listed there. And next. So I just went over some general strength and limitations I thought of the study. So some strengths, there were several different surveys and questionnaires used to obtain a well-rounded assessment of the patient's health-related quality of life. Like I did appreciate the fact that they did look into like anxiety and depression, and they did compare it against the German public in general with a similar age and gender. They did look into their respiratory compromise compared to COPD group and general German public and overall like well-being. They did use several different statistical analyses throughout. They used all this SPSS software and a lot of stats, so they did get a lot of numbers, which I thought was helpful to kind of truly look at the data and look what was significant. And all patients received a similar standard of care because it was in the same medical center, and they were all considered equally. The limitations was it was only one medical center. It was only a retrospective observational study, so there was a risk of selection and reporting bias. There was some patients lost to follow-up, and then therefore there was distortion of reports due to missing data. So you see that, there was 289 patients, and then at the end there was only 53. So what kind of happened in between? So the study did note that in their limitation section, and it did note a loss of follow-up 4 years after initial hospitalization stay was 27%. So that was, of 200 and however many group, or even down to 129, 27% of that is a lot of people. And a quarter of the patients didn't participate in the complete full study, getting all that health-related quality of life at the end. That's why it jumped from like 129 to 53 at the end. So overall, the conclusions, patients with severe pre-existing conditions and poor general state of health prior to ARDS die frequently during ECMO support compared to patients with less severe pre-existing conditions. Favorable long-term survival and high levels of health-related quality of life were seen in this study, with a median of about 4 years of the patients followed up. Apart from minor physical limitations and moderate pulmonary limitations, the quality of life was overall pretty high. And I think something that we could take from the study is that just a larger study is recommended, and I would like to see across like multi-center, versus just one place. But I do think, they did a good job with the study that they did. And so my question is, what was the only statistically significant independent predictor for 6-month mortality of patients in the study? A, ICU length of stay, B, duration of ECMO support, C, pre-existing condition, comorbidities, or D, duration of mechanical ventilation.
She said C, there's somebody saying C here.
It's B.
It's B, right? She said that it didn't matter in this particular study. I mean, you're right, and probably makes sense to be C, but in this particular study, they didn't find that comorbidities affected the long-term mortality.
And it's my reference.
And it's B. So just the duration on ECMO, how long they spent on ECMO. I love it.
Yay.
You guys did a great job. But before one second. So before we leave, I know we have 5 minutes, but we have to leave in 5 minutes. This has to be answered, and this has to be filled. And you write your name on the, if you didn't write it already, on the attendance sheet. And please, every one of those 3, you have to write your name, because otherwise we won't be able to give you anything.
Or did you guys get it?
This friend here is not gonna give us any CME if we don't, if we don't fill this. So the second question is related to Professor Gonzalez's article, which is, which of the following is not a major risk factor of mortality for patients receiving VV ECMO for COVID ARDS? You're really tough. High SOFA score, obesity, age more than 50, and lower PF ratios. Obesity, yeah. So obesity was not a major factor. I remember that from his presentation. There was one more article, but I think Ryan couldn't log in. He's post-call, so he couldn't log in for Zoom. But I can tell you the answer here is what? Prone positioning in VV ECMO, should we not do it?
Did we do it?
Double negative.
Should we not?
Should we not do it?
So if you don't
No,
do
we
it,
should not do it.
Actually, the answer is according to the study, but we'll do that the next meeting. But we have to answer that. The answer is no. We should do it actually.
Should we not do
We
it?
should do it.
We should do it. So the
Right,
answer is
so
no.
we should not,
So the answer is
do
no.
Not do it. Now this one.
Whoa, that's a
this is-
post-call
This
question.
is the sadist.
Yeah,
This thing.
he was on call last
Well, he's
night,
using
so-
the thing that we use in say in ICU, should we not do it, based on studies and stuff like this. So I need to hear, quick comments, everybody 1 minute. Dr. No? Uh-oh.
Oh no.
Oh no, Dr. Morandi? I mean.
Open it up, see who's there.
Uh.
Some of them might be gone.
I think that's it.
Yeah, that's
Uh-oh.
it.
There's only 2 persons.
Uh-oh. Oh my
We
God.
lost, there was some
Professor
attrition.
Morandi, take a picture of this. Take a picture with your phone. Let's just come here, all of us. Everybody on the
If you
screen.
could get the 15 pounds off, I'd come.
Alright, everyone smile. With your eyes. Oh yeah. Alright,
I
I
love
got
it.
pictures for
Okay,
you.
so Morandi doesn't even hear us. Professor Lumpkin,
I think Sharon's the only one on it.
what?
Sharon's the only one left on the video.
I know. All right, Professor Gracioso.
Comments?
General comments.
Oh, yeah, I mean, the studies are small. I guess if I were to say what I would have predicted the long-term outcomes were and then percentage of people that survived, I would have just on Gestalt thought it was lower. So I think it offers some proof in concept that people who go on ECMO, who are gonna die otherwise anyway, a substantial percentage can be saved, and importantly, they seem to have a reasonable quality of life. I mean, think about, the NNT for what we're talking about is lower than most of the interventions that we do. Even if we're talking about 2 out of 10 patients who survive and have some quality of life, or one to 2 out of 10 patients, then that's still an
you just
NNT
treat that
of,
of one.
you know, right, and we routinely do interventions where the NNT is 20, 30, 50. The NNT to save a life for
Steroid.
acute coronary intervention in an isolated inferior MI is nearly 100.
You have to treat 100
We
patients.
think, right, versus medical therapy.
Yeah.
So we routinely do very invasive things with an NNT that's much higher. So I guess that's what it
That's a
means
great
to me.
point.
It means that it's proof in concept that there's value in doing it, and that it doesn't seem from that study that you presented, Emily, to I'm not sure if I'm pronouncing your name right,
Oh, yeah,
but
no, you are.
Um,
Don't worry.
AOL.
that it does not seem to produce more ICU related trauma per se, versus maybe some other interventions that do. I don't know, that's what it means to me. So I was surprised that the numbers
one
looked
of
that
the
good
thing-
in longer
I
term.
was too, when I was
One
reading.
of the things that are very interesting, and I know we know that, but it's you mentioned it in your second slide, and that's really the gist of ECMO, is that you're gonna rest the lung. That's what you really want. Is that the lung will take 3 months to recover if you're really using the lung to oxygenate the patient, and the lung is the organ of interest or the organ that is injured. If you how are you gonna relax the organ that's injured? It's essential for breathing. So if you do the ECMO and you relax the lung, like go down on your ventilation or just do CPAP or even extubate the patient, if in really extreme situations, then the lung will recover faster. Professor Bertucci?
My concern is not whether it's working or not. My concern is always in a small community hospital where we have 16 beds and very limited access to staffing. And as we've discussed, I have probably 2/3 of staffing is our staffing, 1/3 is travelers. Of the 2/3, probably 1/3 are new people under 2 years of nursing getting out of school with experience. It's just very difficult for them to learn basic needs in doing all this, preventing the VAPs, preventing the central line, the class Bs and the CODIs, and getting them up to stuff. Is it something I would love to do eventually? Yes, but I really, in my heart of hearts and my educational background, I just don't know if this is what we could do right now.
No, I mean that's the same
But
thing. That's
again,
the same
it's
thing.
something that I would
but
love to
That was
look
the
into.
same concern before we started the CBVH. It was the same thing. Could
Right.
we do it? Could we not do it? And all of these things. And at the end of the day, I think we have a great new staff, if you will.
We
And actually, the younger people are more receptive to these type of interventions than
Right, because they're very interesting, but they don't know what they don't know, so they don't know what can be caused from this.
Well, of course.
So, yes, they're very excited, but like you said, if you get a clot, they don't understand that that's gonna kill them right away.
Yeah.
You know, it's what they don't know is what
Hi, Debbie.
concerns me, where what I know.
Hi.
Yeah, so, but the other thing also that we all fail to, I think we all like, everybody, when we talk about ECMO, everybody has something in his head. The ECMO that we've seen in my training or in your training or,
Okay, thank you.
Dr. Graciosa said, that ECMO was scary.
Right.
And the technology is getting better. It's not like we're getting better, it's the technology is getting better. The technology is coming to us, making it much easier for us to do things that we
I
wouldn't
agree.
otherwise do. The CBVH, I remember when I used CBVH in the Brigham, it was a disaster. It was like people would cry if you assign them to a patient with CBVH.
Right.
And now it became like, almost
But I think
standard.
we have a limitation too, because I mean, you're gonna need somebody pulmonist, nursing wise, that needs to be in-house 24/7 in case something complicates, is from what the company told us when we had this.
No, not the perfusionist, no. The perfusionist, that's also for the previous ECMOs. So I confirmed to the company that actually this model is made for nurses to take care of. Because the old one was perfusionist and there is like, purging the circuit and all of these things. This is like now is like, it becomes much
Well,
easier.
Right, so I'm listening to the old thing, so, I mean, again, you can bring it in and just see, but again, they were also explaining at that time with the old system that they would only recommend us keep them 24 hours anyways. So there's a whole lot of, I'm hearing what they said back in March, cause I pulled up my notes today, back in March, compared to where, this March, where we're now saying, oh, it's a whole new machine, it's a whole new everything.
Yeah, no, I've been in emails with them, and I actually brought this stuff up to them and said, what was about the 1 day thing? I didn't hear that. I thought I'm the one that's bringing it up, and they confirmed that. I was the one that brought it up to make it easy to swallow in the hospital, to say we're only gonna keep him for 1 day and send them out.
Oh, no, that's what they company actually,
Well,
yeah, that,
Anyway, they didn't say, they're saying that they didn't say that, but I'm the one that said that, and they just echoed what I'm saying. Okay, community hospital, keep it 1 day and get them out.
yeah.
That was the original thing, and I you know, we can talk about that later, but I asked about also, because after the last meeting we had, I asked us, what happened if we cannulate somebody and send them out? Are we gonna have like total loss because, you know, they sent the patient out and they didn't keep him? And they actually sent me a huge email, and I'll forward it to you, with all kind of billing things and stuff, and they said, you know, no, there's actually, the cannulation side gets something significant out of the DRG. But anyway, that's not our focus, the DRG, our focus is.
No,
Just to
my
see.
focus would be, again, if it's a 24-hour and we have to slip them out, then to me, is it worth it to do all this training? I mean, if it's something that we're gonna be able to keep here, and that's a whole nother different conversation from the one we had a year ago. When we had it a year ago, what I understood and Bobby understood is that it was a 24-hour day, and then we're shipping them to Boston
Yeah.
at that point, and we weren't doing ECMO if we couldn't get a bed ahead of time.
Mhm.
So it's again, it's like apples to oranges, if it's a
Yeah,
different
so
system, then it's.
we'll have another meeting with them and see what's going on,
Mhm.
and take it from there. All right, any other comments from our respiratory people, our nice interns? Nice minds? You're like you're a whole category now. All right, thank you very much, everybody.
Thank you.
Thank you for coming.